Dr. Jayashree Baruah, who is from the eastern part of the country, from Jorhat, Assam, to speak on topical MSICS tips and tricks. Today's ophthalmologist, when we have become refractive surgeons, and our patients not only expect good outcome, but they expect a completely painless surgery, and they are not even willing to take that small injection which we would give earlier. So this is what gave phaco a huge advantage over other types of cataract surgery, even the femto phaco. But I think with SICS also, Dr. Jayashree will be telling us how.
Yeah, thank you so much, Dr. Parikshit, and welcome one and all. Good morning. So I'll be basically discussing on how, not how we are doing the surgery, but the basic tips and the tricks which we can follow to convert from peribulbar injections to topical anesthesia. Now, why are we talking about topical MSICS? Now, we have been operating upon our phaco patients and we send them off without giving the patch nowadays. So even our SICS patients, they deserve this benefit. We need to see the smiling faces in all our patients, not only in our phaco cases. So it's the ultimate form of low-risk anesthesia. You have a non-invasive technique, but I say that it's ultimately a personal choice. And it is the surgeon who is to decide whether you are confident enough to shift from peribulbar to your topical anesthesia. Now, is topical anesthesia safe in MSICS? Now, most of us I know are doing topical MSICS, so it's for the beginners. So what are the things that come to our mind? Is MSICS possible under topical? Can it be done in all the cases? And does it require, do we need to modify some of our steps while doing this surgery? Now, as Dr. Gogte has already mentioned, we need to come out, do we actually need to come out of our comfort zone which we are having with the peribulbar? You have echinacea, you have a wonderful anesthesia, so do we need to come out of it? See, every technique there should be a scope for improvement, and anesthesia, it's also the same. Now, it took me just a personal experience, it took me 40,000 plus peribulbar SICS cases to ultimately decide to shift to a topical MSICS. But it took me just 38 phaco cases to shift into topical. Now, why was this? So I sat down and I analyzed my records. So I was completing my SICS cases in 3 minutes, and I was doing it under peribulbar. I was completing my phaco case in 10 minutes, and I was doing it under topical. So what was the difference in my mode of operation? So why didn't I shift earlier? Was I worried that the patient will experience some discomfort? I was still using the superior rectus bridle suture, which I have left now. Will the heart nucleus management be difficult? And what if I get a complication? What if I land up in a PCR? Or was I just searching for an excuse maybe for avoiding peribulbar and shifting to topical? So before understanding, before trying to jump into any conclusion, I decided to just analyze that where actually we are working upon. So we have our sensory terminations of the 5th cranial nerves that are concentrated in the cornea and the ciliary body. And these are the areas where our topical anesthetics are working, and these nerves, they are blocked by a minimal concentration of the drug. So definitely we have the advantages. You don't have the complications of peribulbar injections, you have a lower intraocular pressure, and you have the return of sensitivity soon after the surgery. But initially, yes, there are limitations. You have to choose cooperative patients, you have to choose the easier cases in the beginning. Avoid doing it when you anticipate a long surgery or when you know that it's a complicated case. So for me, it's always the proparacaine drops. I have never used the lignocaine jelly, but yes, they do help us at times, and most of us prefer to use it. And intracameral lignocaine nowadays, they work wonderfully. We have intracameral injections that work with your dilatation, that helps you with your anesthesia. So the technique is the very simplest of all. So you have a preservative-free anesthetic agent. You ask the patient to look up, instill a drop into the fornix, ask the patient to close his eyes, and your job is done. But try to avoid the cornea to avoid the epithelial toxicity, and try giving the drops on both the eyes just as to eliminate the squeeze response of the patient. It's going to help you a lot. So we have basically 3 ingredients for a successful topical MSICS. You have to prepare your patient, you need a careful patient selection, and you need your own preparation as well. So coming to the first point, the patient preparation, adequate preoperative counseling is very important. You have to remember that the microscope light is very bright initially for the patient, so start with a dim illumination, then once the patient is adjusted, you can slowly increase your illumination. You have to remember that the patient has his intact eyelid sensation, so don't fiddle too much with the speculum. And then thirdly, it's very important that the patient can obey your command and control his movements according to how you want. And it's normal to feel some pressure sensations inside the eyes, and the patient should be aware of this. So next, coming to the patient selection, you have again 4 suggestions to pick the winners. There should not be any communication problem between you and your patient. The patient should be able to follow your command, follow your what advice you're giving him. Choose the easier cases initially. And when you're seeing some patients in the OPD, when you're doing your AT or other procedures, you come to know whether the patient will cooperate in topical MSICS or not. So avoid fuzzy patients. So it's basically the preoperative counseling and a careful patient selection that maximize your chances of success and minimize the stress factor both of the patient as well as the surgeon. We also as surgeons, we need our own preparation. We have to understand the eye movement control. We have to understand there is the intact sensation of your periocular tissues and the sensitivity of the iris to surgical trauma. Initially, saccadic movements can be disconcerting, but more forceful movement can create a problem for you. Can I take a minute?
Yes, of course.
You have to be aware that the patient will be sensitive to traction on your speculum or the stimulation of your eyelids. When you're taking out the nucleus, at this point, maybe initially you can go for the intracameral injection because stretching can be painful for the patient. So it's up to you to decide whether you are apt enough to shift from peribulbar to topical. It is the patient who is going to decide how he is going to cooperate while you are performing the surgery. It will definitely depend upon your skill and experience and the type of cataract you are dealing with. So these are the immediate post-operative pictures, and you can see the smiling faces in this too. And why I picked up these 2 patients, because both of them were they had a little psychological problem, but this was the case where I opted not to go for phacoemulsification because I was worried that they may just, they can get up from the bed, so how will I manage such a case? So it was basically a combination of topical and your vocal anesthesia, how you talk to the patient while you are performing the surgery. So I hope this presentation was useful to improve your confidence, to maximize the chances of success, and enjoy your experience of MSICS surgery. Thank you so much.
Doctor, one just question. Would you be doing a topical anesthesia on all your SICS patients, or you would really select them?
The selection criteria I have dropped down to maybe 1 person. Like the patient, I had a patient recently who was operated, and all my colleagues and my assistants, they know that I do all the cases in topical anesthesia, but since she was mentally retarded, she didn't allow even other investigations to be done. At that moment, I was worried that whether I should go for peribulbar or I should go for topical, and it was on table. After taking the consent from all my assistants, they all told me, ma'am, injection dal lijiye, don't do it under topical. But somehow my crux was telling me, that no, if I push the injection, she'll run away from my OT. And so I just calmed her down, and it was done totally under topical anesthesia, no xylocaine jelly. It was done only on drops. So It's how you deal with the patient that is more important, and definitely your confidence. I will not ask a novice surgeon to just start doing topical from day 1.
How about augmenting it by a subtenon or an intracameral anesthesia?
I go for intracameral. When needed, I go for intracameral, not subtenons.
I think